Our next speaker is Ralph Horwitz, who most of you know. He's Senior Vice President for Clinical Evaluation Sciences at GlaxoSmithKline and the Harold H. Hines Jr. Professor Emeritus of Medicine and Epidemiology at Yale University. He trained in internal medicine and epidemiology at the Royal Victoria Hospital of McGill University and Massachusetts General Hospital. And from there, he went on to develop an interest in clinical research training, which he pursued as a fellow in the Robert Wood Johnson Clinical Scholars Program at Yale under the direction of Alvin Feinstein. He joined the Yale faculty in 1978 and remained there for 25 years as co-director of the Clinical Scholars Program and later as chair of the Department of Medicine before joining GlaxoSmithKline. He was chair of medicine at Stanford and dean of Case Western Reserve Medical School. Welcome.
So let me start by saying that that was an impressive young man who preceded me. Let me also thank the organizing committee for giving me a chance to fly into the Buffalo airport. I had not done that previously. It was a great thrill. It's also a great honor to be here with David Sackett. I met Dr. Sackett for the first time in 1975 when I arrived at Yale to work with Alvin Feinstein as a fellow in the Clinical Scholars Program. In the couple of years previous to that, Alvin had spent a leave of absence at McMaster, where he was in the company of David and Walter Spitzer, among others. And when he returned to Yale, he arranged an annual visiting professor exchange in which David would come to Yale and Alvin would venture north to Hamilton to spend time at McMaster. And I had the opportunity to meet David there on his annual visits to New Haven. In 1977, I did some work as a fellow doing a case control study of estrogens and endometrial cancer. And an abstract that was submitted to the annual meeting of what was then referred to as the Tri-Societies, the American Federation for Clinical Research, American Society for Clinical Investigation, the Association of American Physicians, was accepted for the plenary session of that meeting in Atlantic City at a time when those meetings were well attended, largely by people who took isolated toad bladders and looked to see what the perfusion of sodium chloride would do to the exchange of solute. I was to give the talk the next morning when the night before I decided it would be a good idea if I went up to my room early, practiced my talk, and got to bed to prepare for the next day. But about 10:30 that evening, a large and persistent banging occurred on the door to my hotel room, accompanied by the sonorous voice of Dave Sackett saying, "Horwitz, get up, come out." And sure enough, the other side of the door was David, who insisted that the only way to prepare for my talk the next day was to spend a few hours at the bar down in the hotel. And so we did spend a few hours. I'm not sure it did much for my talk the next day, but it gave me an important and valuable lesson about David's humanity. I'm enormously grateful and indebted to him over the years for what I have learned from him, both in science and in friendship. So I should tell you that I've learned today that the randomized controlled trial is a demonstration that that 65 is the new 40, and that we have just managed to roll the clock back. I'm also reminded, of course, that that great Canadian rock band, Bare Naked Ladies, had a song titled, I believe, "Everything Old is New Again," and so it is with the randomized trial as it is being fitfully reinvented here to see if it has some continued future. I don't know if it does, but I would like to help reposition it with you. And I'd like to do so by spending a few minutes telling you about what I think the right answers and wrong questions may be doing to discourage us. So let me begin by disclosing that I am employed by GlaxoSmithKline, and That point was driven home quite elegantly, I thought, by Jan in his previous presentation. But I must tell you that GlaxoSmithKline gets nervous every time I go out to speak. So they do request that I begin by saying that the views that are expressed reflect mine alone and not those of GlaxoSmithKline, that apparently establishes a safe harbor that protects them from my views when I am outside the company. So let me begin with this little anecdote from a wonderful little book called Plato and Platypus Walk into a Bar. The story goes as follows. A young couple moves into an apartment and decides to repaper the dining room. And they ask the neighbor, who has a dining room exactly the same size, how many rolls of wallpaper did you buy when you prepared your dining room? And the neighbor says 7. So the couple goes out and buys 7 rolls of very expensive wallpaper, and they start papering the dining room. And when they get to the end of the 4th roll, the dining room is finished, and annoyed, they go back to the neighbor and say, we followed your advice, but we ended up with 3 extra rolls. So he says, that happened to you too. If you ask the wrong question, you get the wrong answer. So let's think about the implications. What I would like to suggest in the next few minutes is that the emphasis on internal validity, getting the right answer, has made the quality of the answer more important than the quality of the question. And that when efficacy trials dominate, a collateral effect is to diminish the emphasis on the patient's experience with the disease and its treatment, and these are often better captured in so-called effectiveness studies. Now, I do not want to suggest that we retire RCTs. I consider 65 to be young of age. I want to reposition them, and to do so by continuing to strengthen observational studies and apply them more often in studies of effectiveness, restore the patient to patient-based research, and find a better role for randomized trials. So the messages to take away, for those of you who would prefer to do something else for the next 20 minutes, is that benefits and harms may differ in studies designed for effectiveness rather than efficacy. That medicines that have less efficacy in traditional RCTs may be more effective in real-world use, and that patient-centered information on symptoms, function, and well-being has been neglected too long and needs greater emphasis. So I'm going to take a moment to touch on both right answers and right questions for RCTs, observational studies, and patients. And I'm going to begin with an example from an illustration that you probably know quite well, or some of you may, and that concerns a very popular medicine, montelukast, and its use in the management of patients with asthma. Montelukast is a leukotriene receptor antagonist. It's proved and used in the treatment of asthma, and it is a very widely used and popular medicine, both with patients as well as with physicians. Nevertheless, when montelukast, this leukotriene receptor antagonist, is compared against inhaled corticosteroids and long-acting beta agonists for the management of patients with asthma, it turns out that the steroids and long-acting beta agonists have much greater improvement in lung function as measured with FEV1s, and airway response to inhaled methylcholine, and a greater reduction in severe exacerbations. And to illustrate that, this is a illustration from a paper that is very characteristic of the evidence that was generated in traditional efficacy trials comparing beclomethasone, montelukast, and placebo for chronic asthma. This graph illustrates the results for 3 medicines, beclomethasone, montelukast, and placebo. On the y-axis is the mean change in FEV1, and on the x-axis is treatment in weeks, 12-week follow-up. The top line describes the improvement in FEV1 for beclomethasone, which is superior both to placebo, which is the bottom line, as well as montelukast in the middle. Montelukast is superior to placebo and has been demonstrated repeatedly to be an effective medicine for the treatment of asthma. But as data illustrates, in a number of other studies, was routinely inferior to beclomethasone in these trials. But the effectiveness trials of montelukast found something quite different. 2 pragmatic open-label randomized trials of leukotriene receptor antagonists against inhaled steroids for first-line controller therapy or against long-acting beta agonists as an add-on to inhaled corticosteroids were conducted in eligible patients with poor scores on an asthma quality of life scale or asthma control questionnaire, and at 2 months and 2 years of follow-up, leukotriene receptor antagonists were equivalent to inhaled corticosteroids and LABA add-on therapy. This was reported, as a number of you know, in the New England Journal 2 years ago by a very nice group of investigators who looked at this particular issue. And it very much went along with the experience of patients who reported to their doctors that this medicine works for them and, in fact, often was preferred by them to the medicines that appeared to be superior in the customary pre-approval randomized trials. So a medicine with less efficacy in a traditional RCT may have more effectiveness in this real-world study. Why might this occur? Well, one explanation is greater adherence. Turns out that it's easier to take a pill than it is to use an inhaler. And at least as estimated in the real-world pragmatic trials, adherence to leukotriene receptor antagonists as a pill was about 65 to 75%, compared to about 45% with the inhalers. And so even though when carried out in studies that achieved high adherence for all patients, the montelukast looked superior when used in real-world settings where it was easier to adhere to the pill than to the inhaler. The montelukast looked equivalent to the other medication. There are other explanations that may account for this effect as well, and that, of course, is that the population was much more heterogeneous in the real-world studies. It's estimated that in the asthma setting, that up to 95% of patients who are the intended recipients of asthma medications may be excluded in many of the traditional RCT trials that are conducted. The co-medications are often excluded, and the focus on patient symptoms and patient-related outcomes is often ignored in favor of changes in FEV1 or similar endpoints. And you're all familiar with this continuum between efficacy and effectiveness. It was referred to earlier. It is not a bright line that separates these. It's very much a spectrum, a continuum, and many of our trials, in fact, are on this continuum, some looking more like traditional efficacy trials, others looking like more pragmatic real-world effectiveness trials, many of them being interpreted, sometimes misinterpreted, because it doesn't adequately recognize the distinctions in the way in which the populations are assembled, the treatment is carried out, and the benefits are measured. So my first message is that benefits and harms of medicines may differ depending on the way in which they are studied. It's probably not helpful to us to think that there is a uniform design of randomized trials, and that if we think about the various ways in which they are designed and carried out, we can understand the interpretation and inferences much more directly. Now, I want to follow up on my good colleague Jan's reference to this observational study and reinforce the point he made earlier, perhaps show it to you in a little more depth, and that has to do with what is the effect of postmenopausal hormone therapy on the risk of coronary heart disease in postmenopausal women, and show you what many of you already know, that observational studies showed a greater than 30% lower risk in current users compared with never users. A typical example was the hazard ratio of 0.68 that was demonstrated in the Nurses' Health Study. A typical publication in 2006 by Gradstein and his colleagues in the Journal of Women's Health, contrasted to the Women's Health trial, which found a greater than 20% higher risk in initiators of hormone replacement therapy compared with non-initiators, a hazard ratio of 1.24 in Manson's paper published in the New England Journal of Medicine in 2003. Now, as we've heard, the common explanation for this disagreement was a residual confounding, and that there had been insufficient control for coronary heart disease, for socioeconomic status, for lifestyle considerations, and certainly that may well be playing an important role. But another explanation that I think Jan pointed to earlier was they asked different questions. And the right question leads to the right answer. So what was the clinically relevant question? So the clinically relevant question is, what is coronary heart disease risk in women who initiate hormone treatment compared with women who initiate placebo or alternative treatments? The design of the randomized trial ensures that that is the right question that is asked, and the analysis compares incident users and non-users for their subsequent occurrence of coronary heart disease. But the observational studies asked a clinically irrelevant question. They asked about the risk of coronary heart disease in women currently taking hormone therapy compared with women who are not. The design was women who chose whether to use or continue to use hormone replacement therapy, compared prevalent users versus never users. And as has been pointed out, there are inherent biases in that. But more than that, it really is an irrelevant question. It does not tell a woman or help a woman to decide whether to start treatment, nor does it help a woman to decide whether to stop treatment. It asks the wrong question about the use of the medicine when the right question is asked. Observational studies and randomized trials got very similar results when the results were reanalyzed by Hernan et al. As it was mentioned earlier, the Women's Health Initiative and the Nurses' Health Study got very similar results for risk of coronary heart disease. So the question sometimes matters more than the method. That the randomized trial question was the clinically relevant one, that randomized controlled trials and observational studies get the same answer when they ask the same question, leading me to conclude that research designs are flat. They're not hierarchical, that we must dispense with this notion of pyramids, except, of course, if you want to put the observational study, as we saw earlier, at the top of the personal pyramid, but that they are better thought of as being fit for purpose, and that when the purpose calls for one, they should be used, and when it calls for the other, they should be as well. So message number 2 is that the question matters more than the method, so that benefits and harms may differ in efficacy and effectiveness studies, and the question does matter more than the method. So what about patients? So I've cribbed this slide from a group called the Patient-Centered Outcome Research Institute, which goes by the somewhat awkward name of PCORI in the U.S. It was established as part of the Affordable Care Act, which is under relentless attack in the U.S. Right now. If the economy, if the government shuts down in a couple of days and Bob is furloughed, or if the United States decides to default on its debt, it's all blamed on Obamacare, the Affordable Care Act, and even PCORI. But the Patient-Centered Outcome Research Institute has as its mission, one of its missions, to try and refocus attention on patient-centered information. And so they like to frame questions much like the ones here on this slide. They would ask, how will a particular medicine, how will this medicine affect me? How will it make me feel better or be more active? How long will it take me to feel better or to do more? You say, what are the potential harms or benefits if I decide to take this medicine or switch from the medicine I'm currently taking to this new one? And what's the best result I can expect if my adherence is high? So I'm not interested in what the effect would be if I have average adherence, as was observed in the trial, but I want to know what the benefit would be if I take all of the medicine as prescribed, or what will it be if I'm poorly adherent to this medicine? And is this treatment the best choice for me? Does it fit my lifestyle? Can I expect the risk and benefit balance to be consistent with what I want to accomplish in my life? How will it impact my other diseases and medicines? It is so refreshing to me to see these questions framed and the search for answers in a setting where we have driven these questions out of the design of so many of our randomized trials over the last couple of decades. So the patient-centered information is familiar to many of you because it is often found in part in patient-reported outcomes, which are commonly referred to as a report of the status of a patient's health condition, comes directly from the patient without interpretation by a clinician or anyone else, typically found in a validated instrument. If you are like me and have either worked on PROs or used them, you know how frustrating they can be. They're typically a 40 or 50 item questionnaire. It usually starts out with a question something like, during the past 30 days, have you noticed that your symptoms are 1, slightly better, 2, a whole lot better, 3, much more better than you can have ever expected, 4, wasn't a little bit worse, 5, a whole lot worse. These go on endlessly. We have no way of actually interpreting what they mean at the end. The differences that are observed are usually completely obscured by the method of measurement. But patient-centered information tries to capture the actual clinical dialogue between the doctor and the patient to try to understand how the patient's symptoms are actually expressed, how it affects their daily activities, their physical activities, their social and behavioral functioning, their preferences. A number of organizations have gotten behind this effort. The Institute of Medicine, referring to patient-centered information as being respectful of patients. PCORI, as I've mentioned, focusing on symptoms. But some of the initiatives are going to, I hope, actually change the way trials are designed and conducted. ASCO, the American Society for Clinical Oncology, has a draft report out that I recommend to all of you called Raise the Bar for Clinical Trials. What ASCO has asked is that patients consider enrolling in trials and trialists consider designing studies with 2 areas of emphasis. The first is to look for larger effects than have been customarily examined in trials recently, to substitute for the surrogate variables of patient-free survival, a return to overall survival and larger differences. But they've also asked for something else, to dispense with health-related quality of life PROs that are unable to measure meaningful differences and return to a focus on patient symptoms that represent the cardinal manifestations of disease. For pancreas cancer, for example, they emphasize symptoms such as pain, weight loss, anorexia, the symptoms of pancreatic cancer that are most disabling for patients, and focus attention on their measurement. And they have said to patients, vote with your feet, join trials that seek to find meaningful differences and that measure the symptoms that matter to you, not simply the indexes and scales that matter most to investigators. So I think that's going to force us to look for innovative designs and data collection, to recommit ourselves to qualitative research, to measure patient-centered information, to capture the information longitudinally, to use new ways of capturing that information, including web-based data collection, smartphones, social media, and to find ways of really using electronic medical records in ways to capture this information as well. So my third message is to restore the primacy of the patient dialogue in the design of clinical research, whether they are the traditional trials that I think are going to be more focused and used less commonly in the future, the pragmatic real-world trials that we've heard more about, observational studies that are conducted in new ways that will enable us to capture some of this clinical information, and new designs that, such as the one that we heard today from Don Riddlemeyer, that I think are going to offer opportunities for advancements in clinical research as well. So with that, I'll thank you very much and be happy to take your questions and comments.